Medurstand Understanding Medicine.
I am Professor Aziz Rehman from Medurstand-Understanding Medicine. I have covered hypertension as a complete subject in the chapter of cardiology, but this time I'm going to cover the kidney as a cause of hypertension. You know, the relationship between kidney and hypertension is two-way, but this lecture will be primarily focusing on kidney as one of the causes of hypertension. Any kidney disease, I'll show you the list. Actually, whatever kidney disease you can think of could actually lead to hypertension. Because, you know, kidney is the ultimate regulator of blood pressure. There are many mechanisms which control blood pressure, but kidney is perhaps the main organ which regulates our blood pressure through maintaining renin, angiotensin, aldosterone system, sympathetic tone, water retention or water excretion, sodium homeostasis. So all these mechanisms are involved in the pathogenesis of hypertension. So here we're going to talk about the kidney as cause of hypertension, but actually hypertension itself can cause kidney damage and this may perpetuate. Interestingly, the essential hypertension, the hypertension where we do not know the cause, at least we cannot demonstrate any abnormality, that is also mostly linked to the kidney as a cause. But we do not know that in detail because all kidney functions are usually normal. But there is a theory that these people, they have some problem handling sodium, inherent problem with their nephrons that cannot handle sodium properly or that excretes renin too much. So I think that is a theory. But here we're going to talk about the kidney as a cause of hypertension when we can demonstrate some abnormality with the kidneys. The causes are like any renal parenchymal disease. You know what it means? Any kidney disease affect where the parenchyma is affected. Now you may be talking about any types of glomerulonephritis. There are so many types. And you may be also talking about chronic pyelonephritis or sometimes drug-induced renal disease. So any type of glomerulonephritis and any type of chronic pyelonephritis can cause kidney disease and that can cause hypertension. And then renal arterial disease. There are various types, but I think most interesting is this fibromuscular dysplasia. Fibromuscular dysplasia is a condition which is congenital, may present with hypertension in childhood and is potentially treatable or curable. Then same can occur, the renal artery stenosis can also occur in elderly as a result of atherosclerosis. Then kidney disease can also be, the renal arteries may also be stenosed because of polyarteritis nodosa. Now, I have not included small vascular disease because they would be included here. Actually, all conditions, renal parenchymal diseases, they affect glomeruli as well as tubules as well as interstitium. Some predominantly affect glomeruli, others predominantly affect the tubules, but all are included here, which can affect renal function as well as renal circulation. But those conditions which preferentially affect the main arteries are included here. And this cartoon shows you that this artery is narrowed. You can see that there's a diffuse narrowing of this artery, and as a result, this kidney is relatively smaller and shrunken. So this is actually one of the signs of renal artery stenosis if the kidney is small and shrunken on ultrasound. So practically any kidney disease can cause hypertension. This is because, as I've already told you, that the kidney is the ultimate regulator of blood pressure. Now, I'm going to explain to you the pathophysiology of hypertension due to kidney disease. I think if you concentrate on this and understand it well, then the rest of the lecture will be very easy. First of all, any renal parenchymal disease affecting glomeruli or any renal artery disease, both will reduce perfusion. So I think a very, very important thing is that the renal perfusion, the effective perfusion of glomeruli is reduced. So that will result in ischemia and also reduce flow of sodium into the distal tubules. And this would lead to production of renin. Renin is a hormone produced by the kidney. It can split angiotensinogen into angiotensin 1, and then angiotensin 1 can be converted into angiotensin 2 by angiotensin converting enzyme. So this happens in the liver as well as elsewhere and mostly in the lungs. So as a result of increased renin production, angiotensin 2 is increased. Angiotensin 2 has got predominant vasoconstriction effect, and also it stimulates cardiac contractility. So both increased cardiac contractility and vasoconstriction, which is affecting our entire arterial system, the whole body arterial system will be there will be contraction, and that would lead to hypertension. So I think this is the mechanism. Reduced perfusion leading to ischemia, leading to increased production of renin, and renin converting angiotensinogen into angiotensin 1, and then angiotensin converting enzyme converting angiotensin 1 into angiotensin 2, angiotensin 2 causing vasoconstriction and hypertension. But there is another thing which is occurring. This angiotensin 2 also stimulate production of aldosterone. Aldosterone comes from the adrenal gland which sit on the top of the kidney. So aldosterone is increased. There is hyperaldosteronism, and this would cause sodium retention because that is a function of the aldosterone, and also water retention. So sodium retention and water retention would also aggravate hypertension. And this hypertension can potentially further lead to kidney damage and further reduction in perfusion. So this cascade continues unless you intervene with effective medication. This would progress to severe hypertension and more kidney disease. So I think this is very, very important to know the pathogenesis. When to suspect kidney as a cause of hypertension? Number one, when we have somebody who has kidney related symptoms, like he has noticed reduction in urine output, or urine is frothy, or patient gives history of swelling or puffiness or shortness of breath or pallor. So all these symptoms would suggest kidney disease, and sometimes it may be an incidental diagnosis. In the workup of hypertension, when we make diagnosis of hypertension, in the first evaluation, it is recommended that the kidney function should be done. Creatinine should be estimated, and eGFR should be determined, urine should be tested, and maybe from that you could suspect renal disease as a cause of hypertension. Then refractory hypertension. Any hypertension may be refractory, but there are more chances if somebody is really refractory, if somebody is taking medication in the proper dosage, proper combination, still blood pressure is not controlled, compliance ensured, and then blood pressure is still not controlled, so you should suspect renal disease. There are other possibilities, but out of secondary causes of hypertension, kidney disease is the commonest. So I think in this situation, I'd like to investigate kidney as a potential cause of hypertension. There may be other situations also, but these are the three which I think are common ones. And on physical examination, you may see edema, which may be pitting on the ankles, on the scrotal area, on the sacrum, or on the periorbital region. There may be renal masses. One of the causes of renal hypertension is polycystic kidney disease, and in polycystic kidney disease, typically in adults there is bilateral renal enlargement. Sometimes it may be large masses filling whole of the abdomen. So renal masses may be one sign, and renal bruit. If you auscultate on the renal artery carefully from the front or from the back, you might actually hear the bruit. Of course, you need a lot of experience to differentiate this bruit from other bruits in the body, like aortic bruit. So, but if it is located on the kidney area and is on the one side, it is very likely that it is representing renal artery stenosis. Renal artery stenosis may not be a common condition, but if you diagnose it, there is a possibility of curing the patient. So I think important condition. Now, how do we diagnose? On history, we can suspect. On physical examination, your suspicion will be further strengthened, but of course, we need formal investigation. First of all, let's talk about simple urine complete examination, which should be done on all patients who are diagnosed with hypertension, particularly if you suspect kidney as a cause. So simple urine examination may show proteins. Proteins are normally not present in urine, and if proteins are present, especially if it is detectable with dipstick method, that means there is significant proteinuria and definitely background kidney disease. Then active sediments, that means if urine is examined under microscope, the pathologist might see many things like RBCs, WBCs, hyaline cast, RBC cast, and other stuff. So this would be very, very indicative of renal cause of hypertension. Then so-called renal function test. There's actually a long list. I'm going to talk about them when we talk about renal failure, but just one indicator of kidney function is serum creatinine. You know, serum creatinine varies from person to person, but it should be mostly below 1. In elderly, it could be up to 1.5 milligram per deciliter, but if it is more than that, and if it is more than the range in that given age, you should suspect kidney disease. And from that creatinine, plus patient's age and patient weight and patient gender, maybe patient ethnicity, we can determine GFR. So GFR would also be reduced. So that would be an indication of kidney disease. Then we will have to do serum electrolytes. You know, electrolytes are also excreted by kidneys. For example, in kidney failure, hyperkalemia is a possibility. There are other conditions where there is hypertension and there could be hypokalemia, but they are mostly related to adrenals. When we're talking about the kidneys, in electrolytes, you may see hyperkalemia and in some cases maybe hypernatremia also, but mostly serum sodium remains normal because as sodium is retained in kidney failure, sodium is retained, but sodium is retained along with water. So the concentration of sodium remains normal, whereas potassium goes up if kidney functions are significantly deteriorated. Then plasma renin activity and captopril challenge test. Plasma renin activity would be high in any patient where the cause of hypertension is kidney. And please note down, plasma renin activity will also be high in those patients with hypertension who are on medication, like diuretics and many other drugs. All antihypertensive drugs, they have the potential of causing increase in plasma renin activity. So if you're doing this test, make sure that patient is not on any medication for the last 2 weeks, and patient is also properly hydrated. Dehydration can also increase plasma renin activity. If you're suspecting renal artery stenosis, there's a test called captopril challenge test. So in these patients, renin is already high, but if you give them captopril, the plasma renin activity would increase several folds, much more than you would expect in a normal person. In a normal person, also normal hypertension, also captopril will lead to increased renin level, but in patient with renal artery stenosis, the rise in plasma renin activity is much more. Of course, with the availability of better tests, this test is not done very frequently, but this is just interesting to know. Ultrasonography, a very, very useful test. I recommend all patients when they are diagnosed with hypertension should undergo ultrasonography. Although many guidelines they do not indicate this. I'm surprised that many international guidelines they do not advise ultrasound as the standard investigation at the time of diagnosis of hypertension. Probably because this requires human resource and they want to determine or rule out kidney etiology on a blood test. But on ultrasonography, you could determine kidney size. In renal parenchymal disease, both kidney sizes will be reduced. Both kidneys will be smaller and shrunken. In diabetic kidney disease, also kidneys may be small and shrunken. But in diabetes particularly, there could be significant involvement of kidneys and the size may not be reduced. Similarly, in other conditions, if kidney size is not reduced, that of course does not rule out kidney disease, but reduction in kidney size along with some echogenic changes. Now this is not normal kidneys. For comparison, I'll show you the normal kidneys so you see this. Of course, this diagnosis will be given by a radiologist or sonologist, but you can see the difference. Normal kidneys are very different than diseased kidney and the size is different and there's a well-defined capsule. So on ultrasonography, you could determine if kidneys are the cause. One interesting finding is if one kidney is significantly smaller than the other. Why do I say significantly? Because there may be some variation in kidney size in normal healthy people. So if one kidney is significantly smaller than the other, but otherwise kidney structure looks normal on ultrasound, then you should suspect renal artery stenosis, especially fibromuscular dysplasia. Then further investigation should be done to rule out that possibility. There may be a renal hypogenesis or agenesis also. In that also one kidney may be small or may not be visible at all. Then a duplex scan or Doppler scan. With Doppler, you determine flow. With simple ultrasound, you determine the kidney size and the renal artery. And when you superimpose Doppler on the ultrasound, this is called duplex scan. With this, you can measure renal flow, renal blood flow, and of course you compare it with the other side. And if one side flow is significantly reduced, then that would determine the possibility of that will raise the possibility of renal artery stenosis. Now remember, even if you see renal artery stenosis, that does not automatically mean that the stenosis is cause of hypertension. This along with other tests like if it is extremely stenosed, then of course it is very likely to be cause of hypertension, but there is a possibility that there may be small atherosclerotic plaque in the renal artery, but the cause of hypertension is something else. Then final test is CT based renal arteriogram or conventional angiography. You can see the kidney arteries. You can see if this one is normal on the left side. On the right side, you can see the contrast is missing. On my cursor, this is the place where there is stenosis. And if you appreciate, the kidney size is also smaller and it is less well perfused as compared to this one. So this surely shows that the right kidney is ischemic and this right renal artery is stenosed. And most likely this patient should benefit from any treatment which would address renal artery. And this renal arterial angiography not only confirm the diagnosis, it also offers a therapeutic option because a balloon dilatation, placement of stent can also be done through this technique. Prognosis of renal hypertension is perhaps worse than essential hypertension because you already have kidney disease, and one of the main problem we expect with uncontrolled hypertension is kidney damage. So if the kidney is already diseased and is cause of hypertension, then prognosis would be relatively poor as compared to those patients who have simple essential hypertension. But if somebody has renal artery stenosis, that person may be actually cured by some therapeutic intervention. Renal parenchymal disease, because of its own essential nature, the kidneys are extremely essential, that would also increase the mortality and morbidity. So the prognosis, of course, is not very good, but it can definitely improve with treatment, which I'm going to shortly talk about. Follow-up, I think, compared to essential hypertension, patient with renal hypertension should have more frequent follow-up. I think after the diagnosis, I would like to see these patients maybe weekly. After 1 month, I might like to see them after every 3 months. If things are going well, then maybe less frequently. But every time I would expect them to have their renal function test and serum electrolytes. Once I see 3 or 4 readings, then I would know the tempo of the disease. If they are stable, then these tests may be done less frequently. Otherwise, I think having kidney function tests in creatinine and electrolytes every 3 months and a follow-up visit would be very, very useful. Now, in the management, I think first of all, we like to restrict salt and water. This is true in all cases of hypertension, but it is particularly true in people with kidney as a cause of hypertension. Most of us are taking sodium, salt in much more quantity than our body needs. So I would like to restrict salt by maybe 50% or if possible up to 75%. And once somebody restricts salt, water restriction will be easier. Of course, we have to give them the essential amount of water and salt, but since, as I told you, most of us are taking more than what is required, so salt restriction is very important. And then if somebody is taking non-steroidal anti-inflammatory drug or any other drug which is potentially nephrotoxic, I would try to take them off these drugs. Now, of course, I will have to give them some alternate medication, but since these drugs can cause kidney damage and they could contribute to an already existing kidney disease, so these drugs must be discontinued. Then, like in essential hypertension, most authorities, most association medical societies, they recommend angiotensin converting enzyme inhibitors or angiotensin receptor blockers as the first line treatment. If you remember, it is the activation of RAS which is responsible for hypertension. If you remember that slide where I explained the pathogenesis. So that makes ACE inhibitors or ARBs, either one, as a preferred treatment. But in some cases, it could actually increase ischemia and could actually increase creatinine. So I call it two-edged sword. So those patients who have frank renal failure, like creatinine is 4 or 5, I would probably not give ACE inhibitors or ARBs. Those who have creatinine marginally elevated or normal, I would definitely like to give them a chance of with a trial of ACE inhibitors or ARB, but will keep a close eye on the creatinine and the kidney function. If creatinine and kidney functions remain stable or improve, then of course this drug should be continued. But if creatinine and other kidney functions they deteriorate, then we might switch over to another medication. So ACE inhibitors, ARBs, theoretically treatment of choice, but in some cases they may be counterproductive, so you have to be very cautious. That is the reason why I said on every visit, patient with kidney hypertension should have their kidney function determined. Now, if ACE inhibitors and ARBs are not enough, you could add either of these, or if you have to discontinue ACE inhibitors, then you can replace it with any of these. I think I will feel most comfortable with amlodipine because amlodipine is very, very neutral drug. It causes vasodilation. It does not have any effect on other things. RAS would be slightly activated. Maybe then you would need some small dose of ACE inhibitors also. But amlodipine is a great drug. It might also cause some edema, so that will also require diuretic. Primary treatment ACE inhibitors or primary treatment amlodipine or combination. I think that would be the best. But other medicines can also be used as needed. Beta blockers are generally contraindicated. Doxazosin is one of the treatment which we consider when we treat patient with resistant hypertension. Methyl dopa is an old-fashioned drug, but sometime in difficult situation, this might work. Furosemide, because patients with kidney disease are likely to have sodium and water retention, adding furosemide may be useful. And also, if somebody is on amlodipine and there is edema, again, furosemide may be added. And you have to determine the dose. We usually give 20 to 40 milligram. And generally in kidney failure, potassium sparing diuretics are not preferred. Why? Because there is already risk of hyperkalemia. So, and if you give potassium sparing diuretics, there is a possibility of aggravating hyperkalemia. So, but sometimes they may be needed actually. Sometimes you keep an eye on potassium, and mineralocorticoid receptor antagonists can also be useful in these patients. Now, what should be the goal? In most patients with hypertension, our goal is like less than 140 by 90, but all societies, American College of Cardiology, American Heart Association, European Society of Cardiology, European Society of Hypertension, they recommend, a National Kidney Foundation guideline, all of them, they recommend that blood pressure should be kept at below 130 systolic and below 80 diastolic, because they already have kidney damage, so we want to control them more effectively to minimize further progression of kidney disease. But JNC, Joint National Committee on Hypertension, JNC 8 says that just like normal people, we have to keep blood pressure less than 140 by 90. But JNC 8 did recommend that the preferred treatment in these patients should be ACE inhibitors or ARBs. So these are our goals. We will monitor these patients, and of course, with the time we have to adjust the dosage to keep the blood pressure below 130 systolic and below 80 diastolic. Now, this is renal artery stenosis, though not common, but there is a possibility of cure if you have made a diagnosis of renal artery stenosis. Now, this is the renal artery which is stenosed. You could place a stent, and this is the mesh, this is the stent. So, non-invasive, not exactly non-invasive, just without opening the patient, passing a catheter by an interventional radiologist, and deploying a stent in the renal artery could just improve renal perfusion, and blood pressure might come down, or at least your medication might be reduced. Or sometime you could actually have this bypass graft, just like in coronary arteries, and this is the stenosed vessel. And after graft there is restoration of renal perfusion. So these are of course rare situations. Renal artery denervation is also a technique, but if there is kidney failure, kidney function are compromised, then this treatment modality is contraindicated. In some cases, if there is renal artery stenosis and kidney is badly damaged and the differential kidney function tests show that the kidney is not functioning at all it is doing is producing a lot of renin and is causing hypertension, sometime nephrectomy can cure the patient of hypertension. It's very interesting. Now, to sum up, out of secondary causes, renal etiology of hypertension is the commonest. So mostly hypertension is caused by something we don't know, but if it is due to some disease, there are many possibilities. Kidney would be the most likely secondary cause. We suspect kidney disease on the basis of urinary test abnormalities, electrolyte abnormalities, creatinine abnormalities, or some clinical findings, or when patient is not responding well to antihypertensive treatment. Then once you suspect it, appropriate investigation should be done, and frequent follow-up is needed, and tighter control is needed, and renal artery stenosis can be cured. With that, I'd like to thank you. This has been Professor Aziz Rehman from Medurstand, and I really look forward to see you in my next lecture. Thank you.